Welcome to the Essential Substance Abuse Skills webinar series. I am Kate, and today we have invited Dr. Peter Nathan to speak on clinical evaluation screening. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, or ATTC. We are one of 4 national focus centers serving the ATTC network shown on this slide. The network also includes 10 regional centers and a network coordinating office. To learn more, please visit our website. This series is designed to be a broad overview to assist in preparing for written alcohol and drug certification examinations, to enhance existing knowledge, and to improve overall competence in treatment outcomes. Please be aware that this series is not meant to stand alone, and previous education and training is necessary in order to pass alcohol and drug certification exams. We recommend that if you are preparing for an exam, that you seek additional preparatory help, and let this course be one of the many tools you use to prepare. Our next webinar in this series is scheduled for Wednesday, December 17th, when Robert Foley will present Client, Family, and Community Education. We also offer the American Indian and Alaska Native Behavioral Health webinar series, and will welcome Rose Dominick on December 3rd to present Traditional Indigenous Healing. For more information on our webinar series, you can contact me at the email address and phone number provided on this slide. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEHs for a $15 fee. The CEH request form is available in the download in the Files pod in the webinar screen, and I will also be sending this form out in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GPRA evaluation. GPRA stands for the Government Performance and Results Act, and SAMHSA asks us to evaluate our events in order to comply with this act and provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. If you've never used the Adobe Connect system before, you may view the presentation in full screen mode by clicking on the full screen button at the top right corner of the presentation pod, which looks like 4 arrows pointing outward. To return to the regular view, click the button again. You will be muted for the duration of this webinar. Please use the Q&A pod to share your questions and comments, and we will address questions at appropriate points during the presentation. We would also like you to be aware that this webinar records participant attention time. If you minimize the webinar or are working in another window, the system will record your participation as inactive, which may be reflected in the number of CEHs received. Today's speaker is Dr. Peter Nathan. Dr. Nathan is an extensively published author and contributing editor to the Diagnostic and Statistical Manual. He has received the Association of American Publishers Psychology Award for A Guide to Treatment That Works and the American Psychological Association Award for Distinguished Professional Contributions to Knowledge. Dr. Nathan became an emeritus professor of the University of Iowa on July 1st, 2007, although he remains incredibly active in many different pursuits, including being a member of the Emphasis Panel for the National Institutes of Health, the National Institute on Alcohol Abuse and Alcoholism, and a special review committees for the National Institute on Drug Abuse, NIDA, and the NIAAA. As well as his involvement in our center as well. So we want to thank Dr. Nathan for all he does for our center and for joining us today. And I'll turn things over to you at this time. Oh, looks like we might be having a little bit of a sound issue. Let me just try and figure this out. I'll be right over. 1 second. connected. Let me go and check and make sure I can hear you.
Okay.
Okay, Dr. Nathan, are you there?
I am here. Can you hear me better?
Yes, that's great. All right, perfect. Thank you.
Okay. Today we're going to focus on the screening process for alcohol and drug abuse clients. You may work in a primary healthcare setting or in a specific substance abuse treatment center or in a hospital, outpatient clinic, and the goal is to have a relatively convenient and effective process for deciding whether or not the new client you're seeing has an alcohol or drug problem. So the first step in this process is to determine whether the client recognizes the need for change in his or her behavior. And we'll talk about Prochaska and DiClemente and their system for helping you decide whether your client actually is at the point of recognizing the need for change. Then you will interview the client to get a sense of whether he or she describes behaviors that tell you something about their alcohol or drug use and abuse. And then you'll ask some specific questions to further describe the nature of the problem. So we're going to progress through material in the following order. Let me see here. Okay. We're going to first start talking about stages of change and facts about change. I'm sorry?
Could you just lean a little closer?
Okay.
I think it might get us people who are having a little bit of a hard time hearing.
Okay. Then we're going to talk about brief intervention designed to bring about change, differences between screening and assessment, and then specifics about screening for substance abuse. At that point, we will have gone through quite a lot of material and we'll ask for questions and comments, although you can raise questions and make comments as we're going along before we get to that point. And then if we have time, I want to talk about DSM-4 and DSM-5, which represent both screening and especially an assessment process that's important. Then if we especially have time, we'll talk a little bit about treatment options. So let's begin by talking about the system that Prochaska and DiClemente developed. Psychologists working in the 1980s, and their interest was in capturing the change process in cigarette smokers. Oh, things are changing. Okay. And it's interesting, they began with cigarettes and cigarette smokers who had come to them wanting to stop smoking instead of alcohol and drug abuse specifically. And they did that because change is especially willing change is especially important in cigarette smokers. Cigarette smoking turns out to be one of the most difficult processes to bring about. Nicotine is one of the most addictive substances we know about, and therefore we need to know, in Prochaska and DiClemente, needed to know whether the clients who'd come to them were truly able to conceive of changing, ultimately stopping smoking. Since that time, the system has been, the stages of change system has been extended and is now widely used in other addictive disorders, including alcoholism and drug abuse. Okay, I'm having a problem in...
Sorry, Peter, you may have to click on the arrow buttons again to get your keys to work there.
Okay.
There we go.
Yeah. Okay. So Prochaska and DiClemente, in researching their system for capturing change, willingness to change in cigarette smokers, developed a several item system. So clients would come to them often in what they call the pre-contemplation stage. That stage is one where the addicted person, the client, has not really thought about wanting to change. It hasn't occurred to them that change is something that they would want to bring about. More often, clients would come in what Prochaska and DiClemente termed contemplation stage. They'd realized that there were things they could do to bring about change, to stop smoking, to reduce and ultimately stop drinking or using drugs. So they were contemplating the possibility of change, but hadn't really finally determined that they wanted to change. The next stage, again, some clients will come in this stage, determination preparation. The client has decided that they do want to change, has made some preliminary effort to decide how to change, and is ready to change. The next stage action is actually the active change process. The client is taking a number of steps, often under the direction of a clinician, to change. This is where you, the substance abuse treatment provider, are most active. If the client achieves change, gets to the point of sobriety, if we're dealing with an alcohol or drug problem, they've entered the maintenance stage, and they are hopefully going to maintain sobriety beyond the treatment stage. But inevitably, often with patients who've been treated, there is a relapse. There is a return to use. The name of the game is to make the relapse a lapse, a short period of use, and then a return to efforts to change. Finally, once the client has achieved a stable sobriety, Prochaska and DiClemente refer to as a termination or graduation phase. So this is a recap of this. Pre-contemplation, person is not considering change. They don't see their smoking or their use of alcohol as a problem. Then the next stage, contemplation. Client typically is ambivalent about change, has mixed feelings about change, but acknowledges that maybe there is a problem after all. Termination preparation. Client has moved along to being committed to change, has made a more or less definitive decision to change, and that leads the client into the action stage. They're involved in change. They're actively implementing a plan for change. They're working often with a substance abuse provider. They've achieved behavior change in the maintenance stage. They're confronting a whole set of new behaviors, and they're recognizing that there are some undesired behaviors associated with change. This is the stage in which they may lapse, use alcohol, cigarettes, drugs again. The aim here is to make the lapse as brief as possible and to recycle the client back into this system. If they have achieved a stable sobriety, they are terminated or can graduate, and the problem behavior can be considered resolved. That's not to say that at some point in the future, they may very well not have another lapse or two or more than that and continue on in treatment. So this is, if you want to look this up, you can look up the Journal of the American Psychological Society in an article in 1993. So let's talk a little about change. This is what inspired Prochaska and DiClemente to develop their stages of change system. Obviously, change is a natural process. As we grow from childhood to adolescence, from adolescence to young adulthood, to older adulthood, we experience a variety of changes in our thinking, in our behavior, in our relationships. And it's important to recognize that change is a normal part of being a human being. Brief counseling, working with an experienced counselor, can speed up the change process. And those of all of you, I think, are counselors, and you have adopted a variety of brief counseling skills. Important elements of the change process include faith and hope, both on the part of the client and the part of the counselor. Obviously, faith and hope are important elements in Alcoholics Anonymous. It helps to have other supports. That's where AA often comes in, as do counselors who provide this kind of support. Empathy is an important part of this whole change process. As counselors, you have acquired, presumably, substantial empathy, the capacity to put yourself in the client's place, to understand what the client is experiencing. That's reassuring to the client and enables you better to serve him or her. Another element of change is that people often talk about change, talk about resistance to change. And you, those of you who work with clients, know full well that that's an important part of what goes on when you're working with clients in a stages of change process. Now I'd like to talk a little about interview skills. Even though you're doing this, we're talking only about screening here. We're not talking about counseling for change in using substances. I want to talk a little about some skills that have been identified as being important to the counseling process. Then I want to talk a little bit about motivational interviewing and the skills, interview skills that motivational interviewing wishes to instill. So micro counseling is a term developed by Alan Ivy, who was a professor of education at the University of Massachusetts in Amherst. And he did a very thorough and detailed analysis of the skills involved in counseling. He was a professor of counselor education. And this is an analysis of counseling skills. And we'll talk a little about some of them. We're not going to talk, we obviously cannot talk about the micro counseling research program that Ivy developed, but understanding the micro elements of counseling helps you as counselors understand what kinds of skills it's important that you bring to the counseling relationship. Obviously, first of all, important in importance is attending, paying attention to the client. The client will quickly enough observe if you're not attending, and if you are attending, the client will himself or herself feel much more related to you and to what you're doing. So you demonstrate your interest in the client and in attending to the client by maintaining eye contact with the client, by your posture, sitting up, being attentive, and by accurately following the client's talk. So attending behavior encourages client talk, and you are doing active listening, as is the client. Active listening means listening sufficiently clearly and carefully that you understand what the client is saying, the client understands what you're saying. One of the best ways to demonstrate attending behavior is by asking what are called open questions. These are questions that can't be answered in a few words. They offer encouragement. When you use open questions, the client will speak more freely. A typical open question at the beginning of your relationship will be, tell me how things are doing, tell me how you're feeling, tell me what's been happening to you. Closed questions focuses much more on a dialogue between the client and the counselor. It turns the focus on the professional away from the counselor, away from the client. A closed question might be, have you continued to feel depressed? Or is your anxiety still a problem for you? So open questions are typically the kinds of communication that we want to encourage, that Ivy found facilitated communication. So you're going to be observing the client along with your interviewing and your verbal behavior. And interestingly enough, and this is something I think you want to remember, 85%, this is what Alan Ivy estimated, 85% of communication is nonverbal. Maintaining eye contact, sitting up, attending, and only 15% of communication is verbal. There are certain key words that are important. And among the things you will be looking for and listening to are discrepancies in the client's communication. Mixed messages, for example, where the client may say he or she is involved and committed to the relationship, but their nonverbal behavior makes clear they're really not very involved. Contradictions, conflicts, incongruities. These are all ways that the client either wishes or is communicating to you that despite their wish to change, despite their involvement in your relationship, they have ambivalence about changing. So what are you going to be doing to maintain or enhance your relationship with the client? You're going to be encouraging the client. This is a very important part of what the counselor does. You're going to be reinforcing them for behavior, both in the session and outside, that is bringing the client closer to the stage process, change process. You're going to be paraphrasing what the client says. You're going to be repeating in different words what the client has said. An example would be, I hear you saying that you find it pretty difficult to change your behavior. I hear you saying that the behavior that you're giving up has been pretty influential and important to you. And you have very mixed feelings about stopping drinking. Summarizing is an extension of paraphrasing, and that reminds the client, brings the client back to earlier statements. You're telling the client in some sense where you think he or she has gotten to in the stages of change. Important elements in your talking to the client: reflecting feelings. This is very, very important. The client is telling you how, or implying how he or she feels, and you are reflecting those feelings. I hear you saying that you're feeling a little better, you're feeling a little more confidence in your ability to do something about your drinking. The feelings of the client, again, can be nonverbal or verbal. Much of the client's feelings will be nonverbal, and the client will be expressing feelings as the relationship with the counselor continues, will be non-verbally expressing a commitment to the relationship and an understanding of the importance of the relationship. Reflecting meaning refers to the fact that the client will be sharing deeply held thoughts and feelings underlying life experience. Feelings perhaps about parents, feelings about friends, thoughts and feelings about spouse or partner. And those are thoughts and feelings that most people do not easily share with somebody else. But as you've developed this counseling relationship, the client is becoming more and more secure in it and is willing to share these deeply held thoughts and feelings. And you're going to use paraphrasing thoughts. You're going to use reflecting feelings to bring back to the client the things that the client has said to you. I hear you saying that you, in thinking about your mother, you have some feelings about some things she might have done differently. Reflecting feelings, I hear you telling me that your feelings about your spouse have changed over time and that you've become more ready to share with that person some feelings you have about him or her. And this is reflecting meaning breaks down complex behavior. So the client has shared with you a number of these deeply held thoughts and feelings, and you're going to make it easier for both of you to examine them as you paraphrase and you reflect. Empathy, again, this is something that motivational interviewing stresses as well. Actually, many of these micro-counseling skills are also an important part of motivational interviewing. Empathy is basically understanding what the client is experiencing, putting yourself in the client's place. For many years, Alcoholics Anonymous insisted that having undergone change by means of AA, stopping drinking, drug use by means of AA, was essential to empathy, to understanding what the client is going through. That's changed somewhat now, and there certainly are counselors, I'm sure among you, there are counselors who've not yourselves been members of AA and yet have acquired the skill of empathy. Why is empathy important? Well, if the client knows that you understand what he or she is experiencing, you're going to have a firmer relationship with him or her. And you can, as a counselor, better understand the client's behavior. It's sometimes difficult to convey empathy, to make clear that you are understanding what the client is experiencing. There may be language differences or cultural differences between counselor and the client. So I think it's important for the counselor to refer often to the fact that he or she understands what the client is experiencing, perhaps by saying, I think I have a feeling of what you're going through. Is it that you feel that change is turning out to be much more difficult than you thought? So expressing empathy is an important part of counseling relationship. Okay, reflecting meaning, again, motivational interviewing is a system of relationship building developed by Bill Miller and Stephen Rolnick. And the history is an interesting one. In the late 70s and early 80s, recognizing that motivation was essential for clients who had alcohol problems to change their behavior, Miller developed a lengthy 6-hour interview that gathered an enormous amount of data on the client's history of alcohol use and alcohol problems. And in that process, Miller especially wanted to use that 6-hour interview to heighten the client's motivation to change, to move away from their alcohol addiction. And while making that move to emphasize change in motivation, Miller found that if he approached patients with a modified client-centered approach, very much like the approach that Alan Ivey described in his micro-counseling efforts. Client-centered approach was originally developed by Carl Rogers in the 1940s and 1950s. And Bill Miller found that that turned out to be a very effective way of developing a relationship with the client. So as a result, this communication style and focus designed to increase patients' motivation to work on their problems has drawn on Rogers, has drawn on Ivy, has drawn on Prochaska and DiClemente and the stages of change. So what is motivational interviewing? Basically, motivational interviewing is a way to be with people. This is a quote from Miller and Rolnick. Its underlying spirit lies in understanding and experiencing the human nature that gives rise to that way of being. How one thinks about and understands the interview process is vitally important in shaping the interview. So this is the client-centered approach. This is Rogerian, as adapted by Miller and Rolnick. This is Alan Ivy, as adapted by Miller and Rolnick. And it's designed to increase the client's response to screening and assessment, and if the client moves on to treatment, to maintaining commitment to treatment. Motivational interviewing improves treatment outcomes, improves the likelihood that the client will be able to change by enhancing the client's motivation to change. To the extent that the client is strongly motivated to change, he or she will find it easier to change. Now, you probably, well, let me say that many clinicians, many counselors already think they practice motivational interviewing when they screen, when they assess, when they treat. Their skills, their nature of their relationship with the client, the specific skills that they have acquired to better relate to the client, they believe that that's what they're doing, and that's motivational interviewing. But actually, motivational interviewing is a unique counseling approach. Its skills are specific to counselors who've acquired these skills. And motivational interviewing requires attention to such things as timing issues, when you say certain things, specific strategies, when you use specific strategies of change, when you apply specific methods, and how you maximize the effectiveness of all of these skills. It sounds complicated, and to actually be able to use motivational interviewing in clinical practice, it's important that you go through a 2 or 3 day extended motivational interviewing workshop. So we're only talking about the essentials of motivational interviewing here. So there are 2 phases of motivational interviewing. The first is building motivation for reliable assessment and change, asking open-ended questions, affirming the client's motivation to change and interest in changing, reflecting on feelings, and then periodically at important stages of the client's relationship with the counselor, summarizing what's going on. All of this is designed to strengthen the client's commitment to change, building on the client's motivation, increasing the likelihood that the client will resolve to change and will talk about change. So what are the basic principles of motivational interviewing? The 5 essential elements and these are all counselor behaviors. And if you take a motivational interviewing workshop, these will be emphasized and you will acquire these behaviors. The first is to express empathy using a variety of different verbal and nonverbal skills. You'll make clear to the client that you empathize, that you understand what the client is going through as he or she approaches the change process. And you'll develop discrepancy, which means you will contrast the client's actual behavior with what the client ultimately hopes to achieve. So if the client talks a lot about change and about achieving sobriety, and yet continues to use alcohol for a variety of problems in his or her life, those are discrepancies that you want to talk about. The counselor rolls with resistance. That means that when the client comes to the counseling session late or disagrees with the counselor's strategies or with the counselor's interpretations or reflections, the client is resisting change, and the counselor rolls with that resistance, doesn't oppose it strongly, but maintains a consistent relationship with the counselor, with the client, and waits for the client to move along to the point where resistance is minimized. Counselor wants to support self-efficacy and optimism. Self-efficacy refers to the client's belief that he or she can actually change. Self-efficacy refers to the client's belief in his or her capacity to bring about change, ultimately to achieve sobriety from alcohol. The counselor wants to avoid argumentation and direct confrontation. There was a time in alcoholism treatment when argumentation was seen as important, confrontation was seen, confronting the client with discrepancies, with resistance, was seen as important. Lots of research has now suggested that those are not facilitative behaviors on the part of the counselor, and avoiding arguments, avoiding direct confrontation, using the skills of motivational interviewing instead is far more effective. So the fundamental approach in motivational interviewing, collaboration with the client. The counselor and the client are collaborating. So as a result, the counselor is suggesting change strategies for the client's consideration, but ultimately the counselor wants to stress autonomy and self-rule, that basically the important decisions are made by the client with the help and the collaboration of the counselor. So again, 4 principles, and we've talked about these before: expressing empathy, developing discrepancies, rolling with resistance, client resistance, and supporting self-efficacy, supporting the client's belief that he or she is changing, can change, and can ultimately achieve sobriety. A good way to remember common elements of motivational interviewing, especially brief intervention, are the following. And you can see on the left, the FRAMES is the acronym that's used to remind us of these. Feedback of personal risk. The counselor shares with the client, the counselor's sense of the risks the client is taking with his or her alcohol or drug use and abuse. The counselor wants to stress the fact that the responsibility for change and for ultimately achieving sobriety is the patient's. Patient has that responsibility, not the counselor. It's up to the patient to decide he or she is motivated to change and to take the steps in the stages of the change process to move toward change and toward sobriety. Counselor wants to advise the client that change is important, helpful, will reduce personal risk. Counselor will share with the client a menu of ways to reduce drinking. Counselor will use an empathetic counseling style to make clear to the client that the counselor understands what the client is going through and will support the client's wish to change. Finally, the client shares the sense of self-efficacy of the counselor shares a belief in the client's self-efficacy, ability to achieve change. These common elements were developed and created into this acronym when Miller and subsequent author Sanchez developed a brief intervention. This is typically for people who are at the very beginning of a problem with alcohol, and it's designed to move them away from a progression to a more serious, more chronic alcohol problem. So now let's move on. Let's move away from Miller, motivational interviewing, from Ivy, micro-counseling skills from Rogers. Let's move to looking at screening, diagnostic assessment, and treatment planning. Typically at the beginning of a relationship, when a client comes to you, whether you work in a primary care setting or in a substance abuse treatment center, in a hospital, in an outpatient setting, the first part of what you're going to be doing is screening to determine whether, in fact, you think the client comes to you with an alcohol or drug problem. Typically, screening methods are not complex, take a very short period of time, and enable you to make a decision either to move on to a more comprehensive assessment and diagnostic process, or to determine that the client doesn't merit that more detailed diagnostic assessment, but instead perhaps can experience with the counselor a brief intervention or reassurance. If the screening and diagnostic assessment leads the counselor to believe that, in fact, as is often the case, that the client does require a much more detailed evaluation and to participate in planning for treatment, that's the next step. And you can see that that this figure makes clear what the time commitment of each of these things is. Screening takes the least time, but in some ways is the most important part of all of this, because this is the stage at which the counselor and the client determine whether or not the client is going to move on in this process. Screening is designed to reflect the likelihood of the presence of substance abuse, whereas assessment, a much more detailed examination of the client's behavior, is designed to provide a broader range of information for the counselor, for that matter, for the client, on the degree, kind, causes for possible treatments of the abuse. So we're talking here primarily about screening, but we will talk a little about assessment. That's very important. So screening, let's talk about differences in screening instruments and assessment instruments. Screening instruments, and we'll talk about several of them, are typically brief. They require yes or no answers. They can be administered by non-experts, that is, by non-professionally trained counselors, psychologists, psychiatrists, and the like. And they're obvious in their intent. Obvious meaning they are obviously designed to establish whether or not the client is experiencing a substance abuse problem. By contrast, assessment instruments take more time to administer. They ask about more complex, historically based information, both information specific to the abuse, but information about other kinds of things, including the client's childhood and adolescence, young adulthood, and so on. They benefit, these assessment instruments benefit when they're used by experienced examiners. So if you have experience in using certain assessment instruments, your experience will lead you to draw conclusions and to make judgments that would not be available to an examiner who is not professionally trained, is not experienced. Finally, assessment instruments are not always obvious in their intent. It isn't always clear that they're designed to assess substance use and abuse. So how do you screen for substance abuse? What are the elements? There are 4 of them. First is behavioral observation. You will sit with the client, potential client. You'll observe his or her behavior. You'll listen to what he or she says. You'll observe the 85% of the client's behavior that is nonverbal. Does the client sit up? Does the client look at you? Does the client show that he or she is anxious and nervous? Does the client show a willingness to enter into this relationship? Behavioral observation, if you're an experienced counselor, there are many things that you can identify as important to this initial observation and development of relationship. It's during this time, too, that you will be using your counseling skills to develop a relationship with the client. You also, if they're available to you, you'll also want to consult so-called collateral informants, friends, relatives, spouse, partner, family, with the permission of the client, asking for information from them on what they know about the client's problematic behavior, use of alcohol, use of drugs, and so on, including the consequences of assessment in terms of anger, relationship, and the like. If available, laboratory tests. Certain laboratory tests will reflect the problem of drugs. Often different laboratory tests will provide information about long-term use of different drugs. Unfortunately, we don't have good laboratory tests for the degree to which the client has been using alcohol, developed a chronic problem with alcohol, because alcohol metabolizes within typically a day or less, and it does not leave, except in exceptional cases, it doesn't leave traces. And then there are self-report screening measures. We're going to talk about them. That's the fourth, and in some ways among the most useful of the ways to screen for substance abuse. The CAGE questionnaire was developed in 1984 by a psychiatrist named Ewing, and it consists of 4 questions. A cut point of 1, meaning a yes to any of these 4 questions, will yield about 90% of people who come to screening with an alcohol-related problem. The problem is, though, that there'll be 48% false positive, meaning that if you say yes to one of these, the odds are 50-50 roughly that you do or do not have an alcohol-related disorder. So these questions are, have you ever felt you should cut down on your drinking? Have people annoyed you by criticizing your drinking? Have you ever felt bad or guilty about your drinking? Have you ever had a drink first thing in the morning to steady your nerves or to get rid of a hangover? Obviously, if the person who's come to you, the client who's come to you for screening, answers yes to more than one of these questions, the odds are that much greater than 90% that they have an alcohol-related disorder, and less than 48% that they don't. Another 4-question questionnaire, the RAPC-4, the RAPC-4-QF, it's better than the CAGE in identifying whether or not a person has an alcohol-related problem, and it's better at differentiating between people who may be concerned about their substance use but haven't really developed an alcohol dependence. And the reason is that in addition to asking these 4 questions, the counselor doing the screening will ask about quantity and frequency of alcohol consumption, meaning how often during a typical week will you consume alcohol, and quantity meaning how often when you're or how much alcohol do you consume on those days that you are consuming alcohol. Quantity frequency is an important part of these measures, which include, and they're very similar to the CAGE, during the last year, have you had a feeling of guilt or remorse after drinking? During the last year, has a friend or family member ever told you about things you said or did while you were drinking that you couldn't remember? This is somewhat different. Have you failed to do what was normally expected of you because of drinking? You sometimes take a drink in the morning when you get up. So the RAPS-4 is a good deal more sensitive and specific than the CAGE, again, because of this QF, quantity frequency measure. A more elaborate screening tool is the Michigan Alcohol Screening Tool, developed by a psychiatrist named Seltzer. And it consists of, this is the short form, consists of 13 questions. And you'll notice there are numbers after the questions. Those numbers refer to the relative weight that you can put on answers to those questions. So, for example, do you ever feel guilty about your drinking, as a 1, meaning it's the kind of question that a person who doesn't have a serious drinking problem might answer yes about. Whereas, number 6 here, have you ever attended a meeting of Alcoholics Anonymous? That has a 5, meaning that it's the rare person who doesn't actually meet criteria for alcohol abuse or dependence who goes to an AA meeting. 2s are a little more significant in terms of this assessment. You feel you're a normal drinker, and if the person says no, that's significant. Are you able to stop drinking when you want to? Person says no, that's significant. And here are a number of 2s and 5s. Have you ever been in a hospital because of drinking as a 5? Have you ever gone to anyone for help about your drinking? That's a 5. So these 13 questions ask for a good deal more information, and yet they can be answered yes or no, and they're relatively brief, 13 questions. Often people will use, say, the RAPS 4 and the MAST to get a clear sense of the likelihood that the client who's being screened does in fact have an alcohol dependence or alcohol abuse problem. There are also short screening methods for pregnant women. It's obviously important to know whether a pregnant woman has been drinking, has met, or has been drinking to the point where she has a serious problem with alcohol. This is the TACE. How many drinks does it take to make you feel high? Have people annoyed you by criticizing your drinking? Have you ever felt you ought to cut down on your drinking? Have you ever had a drink first thing in the morning to steady your nerves, get rid of a hangover? Obviously, no drinking is by far the most important, preferable behavior for pregnant women. Even women who are heavy drinkers when they are not pregnant, once they become pregnant or think they have become pregnant, it's terribly important, as you know, that no alcohol be ingested. Fetal alcohol syndrome, fetal alcohol effect are typically associated with drinking during pregnancy. The TWEAK is another screening instrument for pregnant women. It includes questions about a question about tolerance, a question about relatives or friends worried about their drinking, question about an eye opener, question about forgetting what they had done when they were drinking. Now, that brings us to the point where we will talk about DSM-4 and DSM-5. At this point, if you've used the CAGE or the RAPS 4 and the MAST, or one of the 2 screening questionnaires, brief screenings for pregnant women, and you've established in your own mind and in your own experience that this is a person who really ought to be assessed more thoroughly because they've shown you in their answers to the brief screening questions that they may well suffer from abuse and dependence, according to DSM-4, then you want to use the questions in the DSM for abuse and dependence, or in DSM-5 for mild, moderate, or severe substance use disorder. And we will talk now about, I will share with you the questions that DSM-4 and DSM-5 ask. You can use them as a screen. More typically, once a screening has determined that the person may very well have a substance abuse problem, you may want to move on to use of the DSM-4, DSM-5 to establish the degree of substance abuse problems. Now, if you're used to using DSM-4, you'll make a distinction on the basis of the questions you ask between abuse and dependence. If you've begun to use DSM-5, you will not make that distinction anymore. Instead, you'll reflect a continuum based on the number of diagnostic questions which you can confirm in your client. And you'll make a decision about whether, based on the number of those questions, that you can answer in the affirmative, whether the person's substance abuse is mild, moderate, or severe. So let's ask about, now this is DSM-4. In DSM-5, there are 13 questions, and they're not separated by those specific to abuse and those specific to dependence. But in this case, DSM-4, you'll ask or assess these 4 questions, and if one or more is answered in the affirmative, then you can conclude that the individual suffers from substance abuse. It only takes one, and these 4 questions are a part of the 13 questions that are assessed in DSM-5. So if the person repeatedly fails to fulfill major role obligations because of substances, role obligation as a father or mother, as a student, as an employee. We all have a variety of roles, and if substances are interfering with the client's capacity to meet those obligations, that's an affirmative response. Recurrent physically hazardous substance use. If the person's job requires sobriety, the ability to concentrate and to maintain balance, or for that matter, to drive a truck or an automobile safely, if substances interfere with that, that's an affirmative response. If the person has recurrent substance-related legal problems, for example, problems with drunken driving, this is the one question that does not appear in DSM-5. Instead, this question asks, does the client report craving for the substance when he or she has either slowed down or stopped using? And finally, does the client continue to use substances despite persistent or recurrent social or interpersonal problems caused or exacerbated by substance use? If the person reports that he or she becomes depressed when they're using alcohol, or becomes angry and some cases physically violent when they're using alcohol, that question is answered in the affirmative. Substance dependence, to meet this criterion in DSM-4, the person has to meet 3 or more of these questions in the affirmative. Tolerance means that the individual has to increase the amount of alcohol consumed to maintain the effect that is reinforcing, or if the person doesn't do that, doesn't increase the amount, they will experience a diminished effect. This is the effect that they look for when they're drinking. dampening their depression or anxiety, their anger, whatever. Withdrawal, person reports a characteristic withdrawal syndrome associated with alcohol, or continues to use alcohol because they don't want to undergo withdrawal. Or if they meet criteria for loss of control and compulsive use, they consume, client consumes the alcohol or drugs in larger amounts or over a longer period intended. So let's say a college student comes to you and says, I've become worried about my drinking because when I go to parties and I've promised myself that I'm only going to have 3 beers over a 3-hour period, and then I find at the end of the evening I've consumed 8 or 10 beers and I've stayed at the party for several hours. Persistent desire, unsuccessful efforts to control use. I've tried repeatedly to get my drinking under control because I realize what it's doing to me and to my relationships. And I haven't been able to do that, so I've decided I need to come here and work with somebody to control my use. The time spent obtaining, using, or recovering from use has increased. The person says that it takes me time to get the alcohol, the whiskey or the beer or the wine that I need to actually consume it, and then later on to recover when I've sobered up, recovering from its use. Important activities are given up or reduced. Typically, it is said that people who develop substance dependence tend to center their lives around activities associated with obtaining, using, or recovering from use. And then finally, the client says he or she continues to use despite a physical or psychological problem maintained by the substance. So if the person says yes and talks about 3 or more of these diagnostic cues, person meets the criteria for substance dependence. 2 of the criteria for tolerance, 2 of the criteria for withdrawal, and 5 of the criteria for loss of control or compulsive use. And again, in DSM-5, this has changed so that these 13 criteria, 4 for abuse, 2 for tolerance, 2 for withdrawal, 5 for loss of control, compulsive use, the number the client endorses will determine whether you judge the client's substance use disorder as mild, moderate, or severe. If they endorse 6 or more of the 13 cues or diagnostic cues, they meet the criteria for severe substance use disorder. If they endorse 4 or more, they meet the criteria for moderate substance use disorder. And if they meet the criteria for only 2, they meet the criteria for mild substance use disorder. Now I'm going to stop at this point, and I'm going to ask for questions or comments about any of the things that I've talked about thus far.
Great. Thank you so much, Dr. Nathan. And I'll just remind people that if you have a question, please type it into the Q&A pad and we will questions from there. If you do have your screen in full screen on the presentation, you'll want to that full screen button again so that you can see the Q&A pod and be able to type into it. So we don't have any questions at the moment. Dr. Nathan, did you want to keep going? And then we can encourage people to...
Substance about other problems associated with alcohol use and abuse. As you know, substance intoxication is often the goal of the person with an alcohol use disorder. And this is an acute condition, intoxication, meaning that it begins when substances are ingested, alcohol is ingested, and it continues, the person continues to feel intoxication so long as they continue to drink. Substance withdrawal occurs when the person stops drinking, ultimately achieves sobriety. This is for a person, for example, who is, say, a college student who drinks and then has been drinking for a long period of time and then stops drinking, and they develop substance-specific maladaptive behavior change. Now, it's important for you to know that withdrawal is specific to the substance that's being used, just as intoxication is specific to the substance being used. That means that alcohol intoxication is different from opiate intoxication, from heroin intoxication, from intoxication from, for example, barbiturates. Similarly, withdrawal from different substances can be different. And I think the important thing here is to note that withdrawal from the barbiturates, the benzodiazepines, is typically more dangerous and more significant than withdrawal from other substances. Withdrawal from most substances can take place in an outpatient setting as the person gradually diminishes use. If a person is addicted to barbiturates, benzodiazepine, to substances of that sort, typically they have to be withdrawn in a hospital setting because the withdrawal symptoms associated with those drugs are sufficiently life-threatening that they have to be withdrawn under expert supervision. So there are syndromes associated with chronic use of substances. So there is, for example, a substance intoxication delirium. If the individual has been drinking heavily for a period of days, he or she may develop a substance intoxication delirium. Delirium involves a disturbance in consciousness and a change in thinking or cognition. I recently had the experience of testifying in a trial of a young man, college student, who'd been drinking for several days, had developed a substance intoxication delirium such that when he went home while still highly intoxicated, he misidentified his apartment door and tried to get into the apartment next door It was locked. He thought there must be an intruder. He broke down the door, and when he found the person in the apartment, he attacked him, and ultimately this person who was attacked died. And the young man was brought to trial and found guilty, not of the crime of the manslaughter, but it was a function of substance intoxication delirium, which is not intended to be a term to reduce someone's responsibility for something like that. Substance withdrawal delirium, when it's withdrawal from alcohol, it's called delirium tremens. It involves typically 12 to 24 hours after a person who's been drinking for a long time stops drinking. They will develop severe anxiety, depression. They may experience hallucinations or delusions. And delirium tremens, if not treated, has a 10 to 15% mortality. People die from DTs. The way to treat them is to provide the individual with barbiturates or alcohol designed to bring them down from, or to enable them to withdraw more gradually than if they became substance-free quickly. We're also probably, if you've been working in the field for a period of time, you're aware of these conditions, even though there is no treatment for them. Dementia is a chronic condition, not acute like withdrawal or intoxication, but a chronic condition involving a more or less permanent change in the brain and behavior. Substance-induced persisting dementia in DSM-4 involves a variety of thinking problems and memory impairment. And there are degrees of this disorder, mild, moderate, severe in DSM-5. This is not unusual. This occurs when a person's been drinking heavily for 20 or 30 years. This condition will develop. Substance-induced persisting amnestic disorder is what is called with chronic alcoholism Korsakoff's syndrome. And this refers to individuals who are impaired in the ability to learn new information or can't recall previously learned information. These individuals cannot take care of themselves. They must be institutionalized. And even in an institution, they will not remember their doctor, their nurse. They may not remember the way to the bathroom, even though they may have been institutionalized for weeks or months. This is a total inability to remember. So this is a sort of once over lightly in terms of delirium and dementia associated with chronic alcohol use. And I will stop at this point and ask whether there are questions or comments about that we've gone through a lot of material very quickly. And the slides, my understanding is, are available to you and they have this information on them. So questions or comments, Kate?
Great. We have a question, Lisa. Has it been determined when the DSM-5 needs implemented in programs?
Say that again.
Has it been determined when the DSM-5 needs to be implemented in programs?
Well, as I understand it, it's being implemented in some programs and an increasing number of programs and an increasingly few programs are using DSM-4. I think there is a final implementation date that may be July 1st, 2015, but it's within 6 or 8 months. But each agency or facility makes a decision on when they want to move to DSM-5.
Okay. And we have a quick question from Krista. Do you have any specific screening tools, recommendations for working with adolescents?
There are questions that are designed for adolescents. I didn't go through them now, but you can use the CAGE or the REP-C4 with quantity and frequency with adolescents and young adults. You can also use the MAST with young adults and late adolescents. But if you look into screening measures, you will find screening measures that have been developed specifically for adolescents. But you can, as I say, you can use the existing screening questions for adolescents and young adults as well.
Okay, and we don't have any other questions at this time, so we want to thank you so much, Dr. Nathan, for presenting today and for sharing your expertise with us. And then I just want to remind everyone, as Dr. Nathan mentioned, we will be sending a follow-up email to everyone, which will include handouts of these slides. So you'll be able to, spend more time with them, as well as we have recorded this presentation, so the presentation will be available. We'll send you a link to that recording in our follow-up email as well. And let me just get to our last few slides here. I want to remind everyone to please join in December for client-friendly and education. And also, we'd love to have you attend our behavioral health series on December 3rd with traditional indigenous healing. And with that, we'd like to thank everyone for joining us today. And again, thank you, Dr. Nathan. Did you have any final thoughts you wanted to share?
No, not really. I thank you for participating. If you want to learn more about motivational interviewing, keep your eyes peeled for workshops in motivational interviewing. And if you want to acquire knowledge of DSM-5, I would guess either your agency or institution will provide that training, or I think there will be trainings that are offered on webinars. So thanks very much for participating.
Wonderful. Thank you again. And as we mentioned, as we close out, you will be redirected to our survey. So please take a few moments and let us know how you found this presentation today. So we will go ahead and close out. Hope you have a great day.